Welcome to Exercise Science 4700 Advanced Gross Motor Assessment here at UVU. I'm Dr. B, and as always, this is my victim. My client, my athlete, my patient. It depends on your setting at an old folks home or a nurse home. Or an assisted living facility. It's a resident. Anyway, today we are doing visual inspection and bony palpation of the hip and pelvis. Of course, we're sanitizing. You just saw that Nate has done that already. And we are not wearing masks because Nate has already had the COVID, so he's developed the antibodies. I've had the first shot and I am symptom-free. And we need to, for the sake of the video, be able to see what I'm saying and what his countenance looks like. Very well. The hip, the pelvis and the hip has one diarthrodial joint, freely moving joint, the acetabulofemoral, triplanar, triaxial, 9 movements, as you know. We have two, and this is arguable. Some will say that the sacroiliac joint is a synarthrodial joint, immovable. I maintain with my experience it is a amphiarthrodial joint, slightly movable. In Hoppenfield, you'll read, he claims that between the symphysis pubis, which is amphiarthrodial, slightly moving, and the sacroiliac joint, that there's no movement there and it's rarely associated with pain. I disagree. I can personally testify. It is not a diarthrodial joint. It has no synovial capsule. It's a synchondrosis. It's overlaid with, which is a subgroup of amphiarthrodial. And I trust you more than me, so do you remember those terms?
Yeah.
Okay. It's covered with soft tissue, ligamentous, cartilaginous tissue, mostly ligamentous tissue, but it doesn't have a synovial membrane or synovial fluid. It's not freely moving. However, it does have a few degrees, and I don't know the number, less than 5, but if you don't have that, you will seize up in the pelvis and there is severe SI joint pain. You typically feel it right around the posterior superior iliac spine, which is at the level of S2, but it's radiating. So I maintain it's amphiarthrodial, it's slightly moving. It's important that the sacrum and the ilium can move to some degree, some slight degree, or you will get low back pain. Here's the PSIS and S2. You'll get low back pain in there. We have several synarthrodial joints with the fusion of the ossa coxa, ilium, ischium, and pubis. So the joints of the hip. Now we're going to get into the visual inspection and bony palpation of the hip. You have asked me to do an assessment of the bones and visual inspection of your pelvis. With your permission, may I touch the bones of your pelvis and do a visual inspection? You have all the power here. There are some private parts there. If I approach anything that makes you uncomfortable, my intent is to do a professional assessment. You stop me before you get uncomfortable. There'll be times when I will have you do some things and point to the place that you give me permission to touch. All right? If you would please shed the shirt and also disrobe down the trousers. And like the shoulder girdle, you're watching the pelvic girdle as he does it. Of course, he's got trousers on underneath. Hoppenfield will say to go down to the skin level, but we're not going to here. To do this, I'd encourage you to practice with baggy basketball pants that you can hike up, or volleyball pants, whatever the style is now. Or, what do you call these, spandex? Or for the woman, Spanx, etc. Very well. With your permission now, we're going to start some more of the visual inspection. Let me have you face me, please. I'm going to start with visual landmarks are going to be the iliac crest. The layman calls the hips this right here, the iliac crest. But truly, the hips are clear down deep to the greater trochanter. So we're going to check for the level of the iliac crest to do an eyeball test, an EBT, for their level. If they're not level, that may be indicative of a pelvic obliquity meaning ASIS and PSI, while iliac crests are oblique to each other, one's dropped. Or it may be indicative of a leg length discrepancy or a dislocate in the hip if they're not level. So we're looking for the level anteriorly of the iliac crest. And I do see he drops his right shoulder. We established that in the past. The narrow of his waist is lower on his right side than his left side. So I make note and anticipate I might see something with the iliac crest when I palpate. And when let's step this way just a little bit. I think I'm stepping out of the image. And when I do the ASIS, PSIS, visual inspection of the iliac crest. Let me have you turn toward the camera. And now I'm going to look at I can see the ASIS right here. That PSIS is too far posterior. So if you can see them with the anterior view, you're also going to look for those landmarks and see if they are level. From a lateral view, we expect to see a slight lower dotted curve. That's for balance and shock absorption in the spine. If that lower dotted curve is missing, welcome to the Boyer family. I don't have much of a lower dotted curve, if any. It's due to paravertebral spasm. If it's exaggerated, it is typically because the abdominals are weak. The abdominals attach down in here and to the ribs, and so they will pull the pelvis up into pelvic neutral here. If they're weak, the muscles in the back are stronger and it will exaggerate a lumbar curve, or it is tightness, so weak abdominals or tight hip flexors, iliopsoas. In closed kinetic chain, the iliopsoas, the hip flexors, psoas major, iliopsoas, open kinetic chain, he is dislocated, isn't he? Is pulling, it pulls, does hip flexion, and moves the femur on the pelvis. In closed kinetic chain, the femur's not going to move, and it'll pull the pelvis on the femur, which leads to pulling the pelvis on the femur. It gives you more of a lordotic curve. So, no lordosis, paravertebral spasm. Exaggerated lordosis is weak abdominals typically, or tight or excessively strong, or contracture of the hip flexors. We have a special test to distinguish that. So that's the lateral view looking for the curve. Let me have you face away from me. Posterior view, again you can see the iliac crest, and he was lower on his left side, but now he's looking lower on his right side. You're going to some degree, but this is not our intent, look at the vertical line of the spine, and you have two dimples in the small of the back. Can't always see them, but those indicate where the posterior superior iliac spine are. So you're looking for those. You're looking for girth and symmetry of the greater trochanters. It's the widest part of the thigh. And checking for any curvature in the frontal plane, lateral curvature of the spine throughout. And having assessed that and making note, let me have you turn and face me this direction here, quarter towards me. Having done the visual inspection, thinking of a youngster, you see the cute little youngsters, the toddlers kicking and flailing, whatever. They have their Michelin man legs with the different creases. If the number of creases are equal or they're symmetric on the legs, then it's normal and the child will fill out and they'll disappear. If the creases are asymmetric, an uneven number, it's one of four things. They either have a congenital hip dislocate, or they have a leg length discrepancy. It may be in the femur, it may be in the tibia. Or they have a atrophied muscles, and there's one more. Congenital hip, a pelvic obliquity. Their pelvis may be off. So a hip dislocate, a leg length discrepancy, muscle atrophy, or a pelvic obliquity. Don't frighten the parents. Just say, you know what, these lines aren't even, and my training tells me, get it checked. It's not a medical emergency, but let's get it checked. Now, we will come to the bony palpation, and with your permission, once again, I empower you. You stop me if we approach anything that makes you uncomfortable. Very well. This means I understand, I agree. Okay, this is an important one to listen with your fingers. And don't just do a token spider walk. Truly listen to every aspect as you're palpating. We're going to start with the anterior view, and with the eyeball test, locate the iliac crest, land your hands on the iliac crest, and then drop your eyes. Don't look until you're settled, and then you're going to take a look for level. And as I compare with horizontal lines in the infrastructure of the furniture around me, those are level, where it looks like this side is dropping if you're just looking at the soft tissue. Iliac crests are level, and you're looking for a horizontal parallel is what we want. If they're not, once again, it's a dislocate or a fracture or a pelvic obliquity for some other reason. From the iliac crest, we're now going to look again and start walking down the iliac crest. The iliac crest is subcutaneous all the way from the ASIS clear back to the PSIS. You step off, you're into tensor fascia lata or gluteus medius, and deep to that is gluteus minimus. We come down to a very prominent landmark right here, the ASIS. And your hands are sensitive enough that you're not just finding the ASIS, you're finding a spot on the ASIS. Some people will step just off and lock their fingers underneath. Personally, I like the most prominent spot. I will locate that, not looking and biasing with my eyes, because if his shorts are not parallel to the ground, that'll make you think we've got a pelvic obliquity. So don't trust your eyeballs when it comes to these things. Locate with your fingers, lock on, and then check for level. And once again, we are level. From the ASIS, we're going to back up, not looking, but listening to the iliac crest. And you'll find about, Hoppenfield says go from the iliac crest and move down about 2 inches. Well, it depends on the bony structure of the individual. I prefer to go from the ASIS, move posterior, and you'll feel that there's a spot where it broadens and it flattens out a little bit, kind of like the triangular flat space at the medial border of the spine of the scapula. This is actually the widest portion of the pelvis, and I look and it's confirmed, and you palpate that area just for another landmark to level horizontal. It's the iliac tubercle. It's the widest and flattest part of the iliac crest. From here, we're going to listen to our fingers, trust them, go back to the ASIS. Lock our thumbs on the ASIS, and we're going to go for the greater trochanter. It's the widest part of the thigh if there's a normal amount of tissue there. However, laterally, they are covered by the tensor fascia lata, the greater trochanter, and by the gluteus medius and minimus muscles. So a lot of soft tissue there. We're going to reach eyeball where they look like, and we're going to reach around behind and pull anterior right there. When you come from behind, they're immediately subcutaneous, so you can hook them, trochanteric hook them from behind and locate them. And then from there, crawl up to the highest part of the trochanter. But look for the same place posteriorly and come out on the greater trochanter. And then we're going to check for level once again, and or any tenderness. Search for, you have bursa here, you have gluteus medius, minimus, tensor fascia lata around this area. Again, another landmark that should be level. From here, Hoppenfield teaches us to go down to the ASIS And at the level of the greater trochanter, we find this pubic symphysis. Well, we're getting close to privates here now, so we need to be really careful in these days, any days. Hoppenfield says to follow from the ASIS, follow the inguinal crease down to the level of where you'll find the pubic symphysis. Some people are heavier than others, and the mons pubis has more or less fat on the fat pad. And before you know it, you might be down into an area you don't belong and didn't want to be, and everybody's unhappy. What I prefer is have the client please touch your belly button. Now you have a bony place just above your privates, and it's soft tissue from here all the way down to that bony place. Please push in a little bit. I'm at the greater trochanter, and walk on down with your fingers, and then you'll feel a bony place above your privates. Okay, mark that spot, and that's going to be level with the greater trochanter. You can go, may I go right to that spot? Okay, and I can feel that pubic symphysis right there just to test for the tenderness. Once again, that's an amphiarthrodial joint. It's slightly moving. The pelvis has to be able to shift. And when a woman goes into labor, a hormone is released that softens that pubic symphysis cartilage and allows the true pelvis to open up even wider. Okay, and it depends on the woman and genetics if it takes up the slack again or not. This is the anterior view. Now we're going to go to a posterior view. If you would please face the other way. Again, we're going to landmark the iliac crest, and I'm not going to let myself be biased with my eyes. And I will look and see that again it's level. With the soft tissue, he has dropped this shoulder. That might emphasize why this is looking lower here, but his pelvis iliac crest is level. We're going to palpate posterior, and that is at a landmark, the joint line between L4, L5. That's how we orient on the spine, L4, L5. And we walk subcutaneous, there's a little more tissue there on the iliac crest, and come down to, typically, I was able to find it immediately without looking, right there. But you can look, and there's a very subtle dimple here and here. This is the location, visual landmark for the posterior superior iliac spine. If you can't see the dimple, it may take some more than usual pressure. Use your thumb. Rather than push, you're going to roll. And you can feel that bone. It is subcutaneous, but there might be a lot of subcutaneous tissue there, fat tissue. And roll to find that you're right on it. And your client has a good sensation of those bones there and can tell you, does it feel like you're on the bone? I'm on the bones? Yeah, and I knew it anyway. So then we're going to do a visual inspection for those. Again, they should be horizontal and parallel to the floor, or window sills or countertops, tabletops, anything like that. Now, there is not a perfect posture. It is position, it is lifestyle dependent. But we prefer to have the ASIS and the PSIS all in the same horizontal plane. We've established that our ASIS are level, parallel to the horizontal, and our PSIS are level and parallel. From a lateral view, he had a normal looking lordotic curve, but now I'm going to compare the PSIS with the ASIS. Turn sideways towards me, please. Okay, without being biased by my eyes, I'm going to find it and then look. And if you look on the film here, his ASIS is lower than his PSIS. Tells me he's got some of this, which is going to demonstrate a lordotic curve. Okay, it's not significant. I didn't catch it with the eyeball test. Do you have any back pain or history of problems? Any problems in the hips, any pelvic pain? Okay, it's noted, but it's not something I'm going to treat or adjust, etc. They should be level He does have a slight anterior pelvic tilt. Coming back to a posterior view, we are now going to go to, from the posterior view, once again, let's go to, this is at the level of S2 for orienting on the spine. We're on the sacrum. The sacrum then, you can't feel the SI joint, but it comes together as we palpate down the spine of the sacrum. We come to a bony prominence, and then it steps off right there. They are different on different people. A person going tubing on the snow and the ice may come off the tube and land on their coccyx, and it will fracture the coccyx right where it articulates, synarthrodially fuses to the sacrum and pop it up into the pelvic cavity. Very tender, very painful. This can be palpated from reaching up inside the anus. We won't do that in this course. And they can actually reach that coccyx and put it back into place. Sometimes this coccyx will be displaced posteriorly when a woman is giving birth and the child is passing down through the birth canal. The coccyx. So we've got the spinous process of the sacrum back to here. Having done the spinous process and seen where the coccyx is, now I'm going to drop back down to the greater trochanter where you can hook from behind. At this level, we have the ischial tuberosity. When that youngster sits on your lap and you say, ooh, you've got a bony butt bone, that is the ischial tuberosity. By way of skeletal review briefly, we've done the iliac crest level with L4, L5. We palpated down to the posterior superior iliac spines. S2, we came down the spine to the coccyx. When you step off, stop, and go back up. You've not contacted the anus, but you're getting close. Then we're back up here. We're going to the PSIS. We're going to reach down and do the hook in the back, subcutaneous greater trochanter. At the level of the greater trochanters is the ischial tuberosity. That's the butt bone. Generally rounded, but some may be more pointed than others or have less soft tissue covering them, gluteus maximus. So that's the, oh, you've got a sharp butt bone. Ischial tuberosity. Hoppenfield points out this is when you do a pelvic assessment, you can do it standing or lying down, supine, prone, and sideline. I prefer standing because a person will likely have pain when they're weight bearing up through the skeleton. So I want to duplicate that situation. When they're resting and supported by the tables, then they don't present with so much of the typical symptoms. You would have, in locating the ischial tuberosity, it splits the difference between the coccyx and the greater trochanter. And actually you have the gluteal fold right there. The crease where the glutes tie into the hamstrings. Having given you a bony visual, let me have you step back, please. I would have the client that is laying down on their side and draw the more superior leg forward to 90 degrees of hip flexion. Standing, I'm just going to have him go to here. So here's his coccyx right there. Here's his greater trochanter. Splitting the difference, you go into the gluteal fold and push up with your thumb. Don't go right into the crease, the crack. You're in the gluteal fold. When he's laying down, here you can see the gluteal fold easy. Coccyx to greater trochanter, split the difference. You push in and up. I wasn't in and up enough. His is hidden now because all of his weight's bearing is right there. But on this leg, so I didn't find it, I wasn't successful. On this leg, it is right there. It's the bony landmark. Your hamstrings originate here. So there's a lot of soft tissues that are there that we'll come back to with the soft tissue evaluation, but that is the ischial tuberosity. And that is, go ahead and relax, come on down. You done good. That is the visual inspection and bony palpation of the hip and pelvis. Thank you, if you would please.